kid, did you want to know how the brain worked? And, you know,
No, actually, so when I was in college doing some shadowing with an anesthesiologist, my first exposure to neurosurgery, I thought it was probably one of the more boring
really?
specialties.
Well, that's
Yeah.
changed.
I looked into an
No spurting
operation.
blood or anything like that.
Yep, saw the brain and thought, man, that's just a boring mass of gray. There's nothing going on here, and I wanted to do heart surgery.
You know, I had the same experience. I snuck into I had to tell that story, but I snuck into a heart surgery. Shoot, this is in the late 80s. And my entire qualifications for being in that surgery as an alleged medical student is that I was in a band with a bunch of the other guys who were med students, and they snuck me in. And I was terrified they were gonna, check my credentials or something. But I walked out of it. It was a heart transplant. I walked out of it, and I was like, I'm gonna be a heart surgeon. So we had the same experience.
Yep.
And I told those guys, I did some, rotations with them, and I was like, look, I discovered after all this that your organ supply is a more important organ, and the blood needs to get up to the brain. I'm going to go up there too. All right. So, but why didn't you stay in New Mexico? Did you want to leave the state? What was sort of your career path?
So I went through my whole life, went to med school here at UNMH. And it's at that point when you live your whole life somewhere, you kind of gotta get out. You have to see what else is there. You have to, it helps you grow as a person to understand and know what's going on in the rest of the world, because the US is a big place and there's a lot of different ways people live, and knowing that and being able to bring it back to your state is really beneficial.
Did you expect to go to some place, New York, California, or something? Oklahoma is just a fascinating left turn, and also a state that doesn't have a lot of neurosurgeons, as far as I remember. I think there's one major medical center, right?
Yeah, that was a really interesting. So for those who don't know, the way medicine works is once you get out of medical school, you have to, in most cases, do some sort of specialization. And while you may know what specialization you want to do, it's a little bit of a black box as to where you're going to be doing that.
Right.
You put in your list of places you want to go, places put in a list of who they want.
The match.
And it gets randomized together. So I think Oklahoma was I think it was maybe my 12th of 14.
Oh, wow.
Oh, wow.
So,
you're in.
Yeah, you're in. And that's it. And that's what they say. And that's what matters.
Where did you think you were going to go?
Oh, man.
What was number one?
Yeah.
Number one, I think at the time was University of Southern Florida.
Oh, yeah.
Or Buffalo, New York, because they had a big endovascular program.
Yeah, I am hoping to recreate what L. Nick Hopkins did there with you. I'd like to build a hospital here that does cutting edge research on endovascular things and blood vessels in the brain and ways to treat stroke. And he was really do you admire him too? Do you know him, the guy who he developed that system?
Not as well, no.
Oh, he's more my generation. I guess I'm old. But he was the first guy that was started putting stents in the brain, for example, and then developing angioplasties in the brain, and just a brilliant guy. He trained a whole generation of folks that probably trained you, and so I mean, I guess that's the difference. But I got my third match. So it's a very, like, when you're a doctor, that moment is really scary, because you go through medical school, you do a bunch of rotations, you try to get good letters and from other doctors that are in important positions, and then you go through this match and you apply and you interview, and then those hospitals that need resident labor, they put everybody's name into a hat, and then they rank you and you rank them, and then where it matches is where you match. And so I thought I was going to go to Chicago. I thought I was going to go to, which is where you ended up for your fellowship. I really, at the time, Dr. Hunt Bajer, who's a real luminary in our world, he was at Northwestern, and I kind of really wanted to go to Northwestern. And but I had built a really strong relationship with the folks in Minnesota, and that's how I ended up there. So anyway, that's it. I can remember opening the letter and just you're just thankful that you got some place to go after all the years, right?
Yeah, absolutely. That at the same time, my partner at the time, who is now my wife,
Uh,
when we had started dating, maybe 9 or so months
she was
before
ready to
then.
reject you and say, if you don't match,
No, I warned her. I was like, "Hey, just so you know, like
I could be a
several months
janitor
from now, we're
tomorrow.
going to be going to some other state. I don't know where, and
I
you're
remember
going to
that.
have to decide if you want to go or not."
Dude, I remember that too. I mean, like it was as crazy as from Minnesota to Albany to New York, somewhere in Florida.
Yeah.
I was lucky. I got a fair number of interviews for a weird reason, which is that I was sort of a computer scientist at the time and had a background in that, and everybody was bringing on electronic medical records, and so that was just one of those things. I had a master's degree in it, and so I got all these interviews, not because I was, oh, they're going to be a great neurosurgeon, because this guy's going to tell us how to program the electronic medical record. Well, interesting. Do we need to take a break, boss? We're good. We'll carry on. All right. Well, text lines.
No. We have to take a break.
Oh, we do have to take
Yeah.
a break. All right. Well, Jerry's got these hand signals. We're gonna get Jerry back on the air. He had talked to us about his atrial fibrillation from last weekend, and he had survived a risky situation that could have caused a stroke. So
it was barely a heart attack.
well, but so now you're like a model prisoner, right? Eating vegetables and
Eating vegetables like a demon, like a veggie demon.
So that means no whiskey for you at the break then, right?
Not today.
Okay.
I'm limiting myself to one glass of wine every 2 or 3 weeks.
I will tell
Okay.
you, I had a patient yesterday we did surgery on who is allergic to squash.
Oh,
Yeah, so we banned all squash from the operating room.
okay.
But be
You
careful.
guys are eating a lot of foods
Well,
during your surgery. So.
you worry about these things, and people.
Oh, that's true.
We've had patients that say they're allergic to steroids, which is what you use for allergies in the first place. So it's I'm not sure that I believe everything that I
Okay.
hear. But no squash for you, just so you know.
No
Oh,
squash.
I shouldn't eat squash, or you don't want me to cross contaminate.
All right, very good. We'll be back, and please call us 505-243-3333. We're taking your calls
Or text the same number.
Oh yeah, we can text the same number, and I think we had somebody from last week. We were hoping Dr. Ernst would stay around to talk about.
Yes. So if you asked me a question last week, that was many bright shiny objects ago, and I've completely forgotten your name. Text us again.
Yeah,
Or call.
Or call.
I think
we'll get you on.
She had called, and she was
Yeah.
trying to figure out the difference between different types of bleeding strokes in the brain.
That's right.
Yeah,
And we promised we were going to do that.
we
Let's do that
did.
after the break.
I know. Come on, you got to find her.
I'll find her.
All right,
Okay.
call us 505-243-3333. Doctor's in. All right, we are back. Dr. Zen and Dr. Greg Scher, 505-243-3333. Text or call. We're taking your questions. My guest today is one of my colleagues, down home Brood Albuquerque neurosurgeon, Dr. Griff Ernst, specializes in stroke and endovascular care. So I wanted you on here as all of the new neurosurgeons. We were building a very big program, and I'm just thinking about the different new trends and things that have kind of changed our practice. One of the things that comes to mind was I remember going to this meeting, and they said that brain cancer, glioblastomas, was finally figured out to be not just like one or two genetic malformations in tumors in the brain, but that it turned out that it was 18 different potential genes that can overlap their miscoding essentially and cause tumors. And the reason that they knew that suddenly, probably about 3 or 4 years ago, was that the neurosurgeons throughout the world got together and started a database and started sampling tissue from every neurosurgeon that would participate in it, everywhere from South America to Europe to here. And we started to look at this it's a very rare disease, and look at the genetics behind it. And so that kind of blew me away because it changed the model of how we could treat it. You could do surgery, which is sort of palliative, cut it out. But, the genetics is the future, and now AI. And so as someone who's trained more recently than I have, like when you look forward to it, is that going to change how you practice in your career? Are you going to be answering to a computer system that sort of tells you what the genetics of this patient are, what they might get, what their tumor could be? How do you, does that terrify you? Like when I think about it, I'm like, I don't want to be told what to do by a computer.
I am very excited about AI. I think it's just about some of the coolest stuff that's out there.
Explain.
It's kind of the way I think about it is when Google came along, we were all blown away by how you could go search through the internet.
Okay, you were like 6. What he's like, yeah, when it rolled in. Okay, maybe you're one of these brilliant guys. You're probably programming at that age, but no. Anyway, so when Google came along, and now you could
have that clip, and now we find out though that there's so much information. What's hard is to actually parse the information, find what you're actually looking for.
Yeah.
And the AI engines create this situation where you can ask it a question just like how you would wonder how something is, and it'll give you an answer as if you're actually chatting with someone, an actual answer, not just a bunch of links of not very helpful websites that don't really tell you anything.
That just searches off of keywords.
Right.
Yeah.
And you can use this for a lot of medicine now. I mean, we're seeing models that are getting used that are applied to all the major journals, and it will provide you a journal-based answer to a question you have.
Yeah, that is incredible. It's sort of, I think there are chat GPT just for different subspecialties now, right? Like I haven't used one for neurosurgery, but I'm sure it must exist.
I'm sure it does. I haven't seen one myself, but I know our partner, he kind of has created his own little one as well.
I got to bring him. He's the chief nerd now. I thought I used to.
Who's that?
Dr. Alvarez. He looks just like me, younger, more handsome, and nerdy. Just knows everything. So I think what's interesting though is that us of an older generation kind of look at it and be like, will it make the decisions about the patients or about the type of surgery without my input, or will I have to defer to it? And that's an interesting problem. I mean, I don't like to give up authority to anybody.
When do you think that AI will? I mean, it's advancing so quickly. Mm-hmm. From the first time I used an AI model until now. Yep. It's leaps and bounds ahead of where it was. And we're talking about maybe 18 months.
Okay.
When do you think that AI will have the ability to recognize the nuances that it needs to know for like what you guys do for brain surgery and for spine surgery? Like how far off do you think that is?
That's such a good question. Someone else what I worked with when I was in fellowship was convinced that it was a couple of years out.
Wow.
That we were going to be superseded by this. I think the big limitation still is the input. I mean, it can
Yeah.
query all this information and do all the things, but if you're the one putting that information in, or you're the one that's asking the question, it's still limited by you. It's still limited
Right.
by where it gets that information. And if you, the physician, don't know where to start or what you're looking at, then the AI is not going to help you as much.
Right. Yeah, because I always tell people too, like, you know, when I started this job, I've told a couple of people, it's like, hey, I want you to start using this program. This is not to replace your work. This is to enhance your work.
Right.
And yeah, I just,
It's exactly the same.
Yeah.
Or at least the way I think of it, it enhances what you already would have to do rather than having to open 3 or 4 different books to find your answer. You
Right.
can just ask the question, get the
Yeah.
answer, and
Right.
then go from there.
I think the usefulness for what I think, first of all, luckily as brain surgeons or spine surgeons, there's a certain amount of judgment that we have to make very, very hard decisions about what kind of surgery we do, when we do it, and that kind of thing. And
you have a
so-
couple of texts that came in.
Yeah, let
Yeah.
me just finish this thought.
Yeah.
So you know, the idea, I've been consumed with the idea that doctors could be replaceable. They got these databases that will tell us statistically what's a better chance of an outcome or something. So, but nonetheless, I think most people would not, if they had the choice, they would say, you know, doctor, I want you to tell me what your judgment is. You're going to have your hands in there. And so we still have a role, but there are, like, you know, I've said before, radiology it could have difficulties with it because everything could be fairly protocolized. And so anyway,
Yeah.
all right, let's see. What do we got, Jerry?
So
some
we've got a
questions?
text. Please explain the difference between atorvastatin and rosuvastatin. The doctor switched him from one to the other. LDL, IDL, around mid 50s. So other than the rosuvastatin is obviously the Russian version. No?
I'll defer that one to
Didn't-
Dr. Ernst. I know about the statins.
Let me get up my
and-
chat GPT. Hold on.
Yeah, exactly.
We usually prescribe them after a patient's had a stroke or an event, and we want to bring down the cholesterol. Is there some major difference between atorvastatin and rosuvastatin?
To my knowledge, it's mainly centered around side effect profile,
Mhm.
and a lot of they basically work essentially in the same way, but some people can't tolerate one and can tolerate the other one better. And sometimes you may not have as great a response to one, and then you get switched, and now you have a much better response. So functionally, they're about the same, but sometimes they can have different side effect profiles and be more efficacious for you compared to someone else.
I seem to remember that. So the mechanism of that is you're sort of poisoning the normal cholesterol production of the liver, and so therefore you're not making your own cholesterol. Is that how that works?
Essentially, yeah,
Yeah.
you're blocking parts of that cholesterol chain,
Pathway.
and so it doesn't get made into it.
Interesting. And I remember there are some people that it doesn't make a difference. Like it does work really well, but then there's other folks that have to be on gemfibrozil or something else that brings their stuff.
Right. And unfortunately, now they have so many different types of those statins that a lot of times they can find what works for you.
They just maybe the texture is feeling ill from that drug. There's nothing wrong with changing statins. I think with the help of a
From one
doctor,
to the
obviously, and but you know, what a useful drug. I mean, I remember reading some of the original studies. Do you remember? I mean, like, it's really remarkable when.
Yeah, they keep finding more and more things that it's useful for.
Yeah. Oh, really?
That more than just it stops cholesterol, but they're thinking this has effects on inflammation in the vessels and many things well beyond just lowering cholesterol.
Oh, interesting.
Wow.
Yeah.
Can you briefly talk about the difference between HDL and LDL?
Oh man, we're really dragging it back. Let's
Yeah,
see.
no, well, obviously the HDL is we think it's you want a
The
higher
better
number. That is the
cholesterol.
better cholesterol to have. High density.
That's your salmon
lipo-
cholesterol, right?
There you
the
go.
good stuff.
Do you think bears in Alaska don't get strokes?
I would imagine. I think so.
No, I think that's a red meat. It probably has pretty high LDL, and then LDL would be the more suspicious of the two. We don't want
Yeah.
that to be elevated.
If I remember correctly, from back in med school, the HDL is your high density lipoproteins and
Yeah.
your LDL is the low density lipoproteins, and the LDL tends to get taken throughout the body and sequestered in places you don't want, and the HDL often helps bring it back to the liver to get changed and digested and reformed.
Yes.
Cool. Let's do one more question before the commercial break. Let's go back to our lovely lady from last week.
Oh, nice.
And
did show
she
up.
wanted to know what are the difference in symptoms for a stroke that is blockage based versus a bleed out?
I'll let you take that one. I think that's more your purview, but at the same time, great question because, man, we want to reduce both of these things.
That is a very good question. And it's also it's a little bit of a difficult question. So the difference between the two is we call them an ischemic stroke and a hemorrhagic stroke. The ischemic stroke is where you have a blockage in the vessel and you're not getting blood flow to the part of the brain, so it's starved of oxygen. The second one is a hemorrhagic stroke, and that's where you have a breakage or a blowout of one of those vessels and blood leaks into the brain. So it's also not getting the blood and the oxygen, but that's because it's leaving the brain rather than being blocked. With the blockage ischemic type, you can kind of see your classic stroke symptoms of weakness, difficulty speaking, facial droop. The bleed kind can present in a number of different ways, but it often will be associated with some headaches and pain because that blood is expanding into the brain and pushing other areas away. And that can present in a bunch of different ways as well, because that bleed can show up in a number of different places.
Is it true that you can smell toast or almonds during a stroke? Is that just something in TV
I've
shows
heard of
and
that with
movies?
seizures, haven't you?
That is more
Yeah.
associated, or at least when I've heard it, with
Yeah.
seizures. And we call that an aura, where it kind of presages a abnormal electrical activity in the brain. And certainly the hemorrhagic version of a stroke could cause seizures. So it's certainly possible, but more likely that would just be associated with seizures more than anything.
But more importantly, what's really cool is why is the olfactory nerve, your sense of smell, more important in terms of your understanding your day-to-day environment than any other of the senses that we have?
You want me to take a guess? My guess is that it's associated with a lot of your emotional pathways as well.
Yeah, exactly. So what's cool about the sense of smell, so I'm sure we all were originally wolves or something, but the olfactory nerve, which it handles both your sense of taste and your ability to smell your environment, those fibers leave the nose and they go up through the base of the skull and they synapse immediately with areas that control your base emotions, anger, frustration, lots of other base hunger. So any of the emotional aspects of smell, that will be the most primal stuff that you have because it doesn't even go through the brain to be processed first. It goes right to your emotional center. It's kind of an interesting fact. All right,
Dr. Sure, you're forgetting the most important
Tell me.
reason for the olfactory experience, and
Yes.
that's so you can know who dealt it.
He who admits it, I think, is
and the emotional pain that comes with it.
Break time.
On that note, yeah, we're going to take a break. 505-243-3333. Give us a call, and we'll take your questions on text or phone calls.
Hey, and you know what? You don't have to just ask brain questions. Like if you have a general medical question, I think these guys might be able to.
Well,
Yeah,
everybody
maybe.
calls in about erectile dysfunction and prostate issues. So
I have a question when we come back. I want to
boy,
know.
here we go.
I know, seriously. I want to know about Bell's palsy
Oh, good.
and how it, what causes it. Is it a type of a stroke? We'll talk about it when we come back.
No, that's a good one. And it was named after a Dr. Bell. So it's not that you hear ringing bells or something.
No.
Maybe you do. I don't know. All right, we're taking a break and call us over that
243-3333.
Bye. All right, you're back with Dr. Greg Scher. Doctor is in. We're taking your calls, 505-243-3333. Here with Dr. Griff Ernst, hometown hero. Became a neurosurgeon, even though he went to North Valley High School. And we are, as a department, we're growing and we're trying to develop stroke outreach and bring neurosciences to the forefront in this state, which has not had a lot of this. It really has. There's very few neurosurgeons, not very many neurologists. So I'm grateful that he's here. We are along those lines taking some phone calls, and I think Sylvia called in, and she has some questions about a TIA. Can we connect her?
Yeah, Sylvia, are you there?
I am here.
Woohoo! All right. Tell us what happened to you, and was this recent?
Yes, about 4 weeks ago, my left arm, the bottom part of it became numb, and part of my palm and my little finger and ring finger. So I took a couple of aspirin and sat in my easy chair till it went away, and then I went to urgent care, and they did a million tests and put me in rest overnight and did a million more tests, and they were all negative, and they called it a TIA. But then they put me on this blood thinner. Well, 2 different kinds plus aspirin.
Okay.
And I did not fall. I did not bump it, but I have these little blood vessels that break in my fingers and the hands sometimes. And one broke, and man, there was blood under the skin everywhere. Now I have a thrombosis, and nobody wants to lance it. It's pretty awful. Is there a way I can get that done? Do you know anybody that does that?
Yes, I think there's things that we could do to help with that, but I want to kind of go back and just talk about your initial event here. So they labeled it as a TIA. They didn't feel you had a full stroke. Is that right?
Correct.
How long did it take for the numbness in the hand to go away? And were you weak also?
No, I wasn't weak. I sat in my easy chair after I took the 2 aspirin. It was about 10 minutes, maybe 12.
Interesting. I think I'm going to defer to Dr. Ernst on that one. So what's the difference between a TIA and an actual stroke? What did she have?
So a TIA, we call that a transient ischemic attack. And the difference between that and a real stroke is this real stroke has permanent damage that you can see in the brain. So a TIA is the symptoms involved, but it resolves before the brain has permanent damage.
What's the mechanism? Why didn't she end up with a full-blown stroke?
It could be that maybe there was a little bit of a clot that went up, but then it was able to dissolve. And so you were able to get blood flow back. So that would be kind of the general idea of how that would happen.
Do you think that most people have warnings? Like, in other words, if you were to go back and look at all the people who had strokes, did they have some TIAs leading up to that? Is that a common story?
It certainly is a common story for a certain amount of the population, but a lot of people also do just have the straight strokes without having those TIAs. Some of that depends on what causes that TIA. If you're someone who has neck vessel pathology and had that for a while, you may be having a number of TIAs before you have a full stroke. But if you're someone that has an abnormal heart rhythm and it sends a large clot up, you might just go straight to having a big stroke.
Yeah. Sylvia, is this the first one that you've had?
No, actually, it's at least the 3rd. It could be the 4th. I wasn't sure about one of them.
And they all are sort of similar. They're always on I think you said your left side?
No, actually not. First one was a whole lot worse. I was driving
Scary.
on I-25, and all of a sudden I didn't know where I was.
Hmm.
And I couldn't see to the right. About half of my right eye seemed to be blocked. Totally different.
Yeah, actually, that's
But I
interesting. So that's the blood vessels in the back of the brain where your eyesight is. That's counterintuitive, but so yeah, that's concerning. So did you feel like they got all the tests and were able to make sure you don't have some cholesterol in your arteries leading to the brain? I mean, did they sort of lay it out for you?
I don't know anything about cholesterol, but they did a EKG on my brain and a echocardiogram, and you name it, they did it. It was,
Interesting.
and all of them were negative.
Okay. So the usual treatment that she's talking about, I'm guessing they put her on aspirin and Plavix. Does everybody end up with aspirin and Plavix? And number two is do they cause this bleeding that she's dealing with?
A lot of people do.
And they
And
also gave me a third medication. It started with a C that I was supposed to take for 21 days.
Coumadin, maybe?
Hmm.
Uh,
Are you
Just
not
for
taking your
21 days?
medication?
maybe Crestor.
No, I quit after this thing with my wrist. My God.
Well,
And I just
let us
sit
just encourage you to at least take the aspirin, even if you're having some side effects from the others. The aspirin will help you. I would do 81
Yeah, I
milligrams
thought
every
I
day.
might do that as soon as this quit, but it's finally stopped bleeding. I've been to the urgent care or ER about 4 times in the last 4 weeks. It's ridiculous.
All right. Well, before you go, I'll have Jerry get your phone number, and we can find somebody who can take a look at your skin and your bleeding there. There's probably a way that we can help you. We'll find somebody. So thanks for calling in, and we wish you luck with it. It is a little worrisome that you've had 3 or 4 of these. So the blood thinners may be something that you want to consider taking. It's potentially something is causing these repeated strokes or TIAs that could lead to a stroke. So obviously try to do what those docs are telling you to do. It's important. Okay. We'll get her some help. And interesting call.
Thanks for calling.
Yeah. Thanks so much for sharing. So now the downsides
Yep.
of blood thinners in older people living longer.
Hmm.
And as I recall, doctors like you have this problem. You save them, you fix their stroke, you put them on a blood thinner, and then the risk that they fall down, hit their head, and have a bleeding stroke from the medication at some point becomes equivalent to the risk of having another stroke.
Mhm.
Where is that now today? Are blood thinners now a problem?
Certainly, it's something to think about. I mean, if you're making it much easier to bleed, certainly the bigger, scarier event is you do fall, hit your head, and now you have this very awful brain bleed that can potentially put your life at risk. I think that's the more rare situation, and just like the last caller was talking about, is when you're older, you fall, you bump into things, and you get these very large bruises. And that's also because your body can't clot. And so you get that bleeding underneath the skin. And I think for a lot of people, that's you see it, you feel it,
Yeah.
and that's
You
can
don't
be
know.
really uncomfortable. Whereas the prevention for the stroke, you don't see on a day-to-day basis.
Yeah, so we're going to take a break in a second, but I think the farther we get along in understanding how to deal with things like stroke, and we were talking about tumors before, sometimes the treatments present with a whole other set of problems that are sometimes even worse than the underlying disease, and so that's a tough deal. We're working it out, though. So the science is developing, and it's an exciting time for us. All right, give us a call, 505-243-3333, and we're going to come back and take Buck's question after that.
Download the News Radio KKOB app. Just search KKOB in the Google Play or iTunes Store.
All right, we are back with the Dr. Zinn, Dr. Greg Scher. I'm interviewing Dr. Griffin Ernst, a tried and true Albuquerque native who made good. He became a neurosurgeon and has come back home, and he's helping me as we're developing stroke and brain surgery in this town. So
New Mexico is kind of like the Hotel California. It's like you can check out, but you can never really leave. You always end up back here,
Yeah,
right?
That's true. I believe it.
So you had a question, Buck, you were kind of wondering about.
Yeah, I was kind of curious about Bell's palsy. I know a lot of people have that. The first time I got it, I was working out at the gym, and I was in the bathroom washing my face after I worked out, and I noticed that the right side of my face was just kind of drooping, and I couldn't blink my eye. And then I got it again 3-4 years later on the left side.
Did you know what it was, or did you think you were having a stroke?
No, I thought I was having a stroke. I went straight to the ER, and they diagnosed me with Bell's palsy, and then I got it again a few years later. So, is Bell's palsy similar to a stroke? Because I know it's not uncommon for people to get it, right?
You want to take a crack at that? It is a
Absolutely.
very interesting pathology.
So it's similar in that your face is droopy, but it's very different in how that happens. A stroke is a primary injury to the brain itself, where Bell's palsy occurs is centered to the nerve, and that's why when
That goes to your face.
that
muscle.
goes to your
I mean, it's like
face
it's that
muscles,
far
exactly.
along, yeah.
And you can tell the difference because when you're having a stroke, the eye and the forehead don't droop. And that's because that part of the facial muscles is controlled by both sides of the brain. Whereas as you go downstream in the information, all of that nexus comes together at the nerve. And so if that has some dysfunction, then the whole side of the face will be weak. And we don't
Interesting.
always know exactly what's causing Bell's palsy, but some of it can be a reactivation of a virus like chickenpox.
My
or
mom
something
had
like
a
that.
wicked case of Lyme disease, and
Yeah.
that's a classic
Yeah.
Mhm.
sign.
Yeah, because I believe they treat it with Valtrex, don't they?
That and steroids.
And steroids, yeah.
Yeah.
Yeah. Huh.
Yeah,
Okay.
so Bell's palsy is it's really an inflammatory problem. It's not a stroke or a tumor or anything like that. It's that so the basic physiology is your brain decides you wants to move a muscle. There's an electrical signal that follows down through the brain, through the spinal cord, typically, and then out to a nerve, which goes down to, let's say, your leg muscle, and your leg moves. So in the face, it's a little bit different. You don't have to kind of go through the spinal cord to get there. The brain controls the movements on the face. But the same idea applies. Essentially, rather than a loss of the signal from injured brain to move your face, the signal is trying to get all the way down there. But as the nerve and meets the muscle in your face, that nerve is misfiring or not firing because it's under some stress or inflammation. And so you lose that tone, the muscle tone that we all have in our face. And
Yeah.
so it's a very distal, or it's a problem all the way down the train line, if you will.
Sure.
Okay. So did we finish up with the whole different types of stroke thing, Jerry?
I believe we did.
With Sylvia? Okay. Well, we have a few minutes left. I wanted to kind of circle back and talk about what the needs are as we look forward in the state of New Mexico. We have typically not had good stroke care, good neurology or neurosurgery care. And I would like to see that change. Now, from when you were growing up as a kid, did you have some sense that this was a very underserved place to be and to eventually be a doctor?
Absolutely.
Yeah.
I think anytime you have kind of a poorer state that is spread out, you have a multitude of factors. It's hard to get physicians to come out. A lot
Right.
of people want to go to big cities, your cities like California, East Coast, West Coast, things of that nature. When you have a poor state, a lot of people don't have money. They're not going to the doctor. You get a lot
It's
of
too far away.
it's too far away. You get a lot of pathologies that have progressed much farther and become much more difficult to treat than if you were constantly seeing the doctor. And
So I think the upside of working here is I see things that I remember reading about in textbooks when I was a young
Oh
a
yeah,
wee lad
absolutely.
that never existed on the East Coast where I
Yeah.
did some of my training.
It's a little bit of a doctor's guilty pleasure. You certainly don't want people to have these things, but
But you can't
see,
believe it.
You see the full scope of it
Yeah.
from start all the way to its worst. You get to see that progression, the natural
Yeah.
course of the disease, as we call it.
Have you had an amazing case, in general terms that you can talk about that kind of like rolled in? You're like, I can't believe how bad this is.
I mean, where to start?
Really?
Yeah, absolutely. You see tumors that you look at it and you're like, this is
It should have been treated
this
a
is
year,
huge.
a year ago. Yeah.
You see infectious processes in the spine that are just unbelievable. You see, I mean, anything and everything, you name it.
I think one of my favorite cases was one of our partners came and said, I think this patient has syphilis in their brain. And I'd only ever heard about it. Like on the East Coast, of course, it's eradicated. It's typically, how is it treated? How is syphilis treated?
I mean, usually you're just getting medication for it. and it goes
Penicillin,
away.
yeah.
Didn't some gangster die of syphilis? Was it like John Dillinger or one of those guys?
Yeah, one of those guys.
Yeah.
Who was the big Chicago gangster? Anyway,
Yeah.
Was that Al Capone?
Al Capone.
Capone,
Al Capone died of syphilis.
Yeah.
That's it.
I think Hitler had syphilis. I don't know. It was going around
That's
back. in the
not a
day.
shock.
So
Freaking crazy.
But yeah, so our partner came in and this guy's got this huge, looks like a tumor, but it's the fancy word for it with syphilis is a gumma, Gumma. And sure enough, we biopsied and turned out, I mean, we hadn't seen this for maybe 30 or 50 years or something. Here, New Mexico had it, right?
Of course.
Yeah. So, but you've come full circle. You left the state, you went out, you got trained, you came back, and is this the right place? Will you stay? That was what they asked me when I started. How do we convince you to stay in the state? Neurosurgeons come and they leave so quickly.
I think one of the biggest things was having the opportunity to leave.
Mhm.
Is you go out and you see somewhere else, and then you realize what it is about the state that you actually love so
Really
much.
liked, yeah.
I mean, we have a gorgeous environment. The weather
Mhm.
is fantastic.
Yeah.
And I've
Yeah,
always
Chicago
felt
seems tough.
I've always felt that the people in New Mexico, even though sometimes they can look a bit rough, they're genuine.
Yeah.
You know what you're getting.
Yeah.
There's no
You
hiding
know where you
behind-
stand with people.
Exactly.
Yes,
There's no
you do.
hiding behind
Yeah.
anything.
Salted
Like
right.
you know what it's going to be, and you appreciate that.
I've had a couple of different. I've been here long enough, I guess, probably practicing since 2019. Earlier, I did some work in Farmington. I've seen a number of patients that worked in the uranium mines.
Really?
Yeah, and it's remarkable. I mean, I don't know that anybody told them back in the day that this could turn into what it.
Yeah.
They come in with 3 different types of cancer.
Sure.
And so my heart goes out to this population of people. We're very lucky to treat them, to be able to do what we do here. But I mean, there are some complicated pathologies in this state.
Absolutely.
I mean, mining uranium as a family, and I've seen 3 generations come in with tumors that we have to take out of the brain. It's been another wonderful hour. I really appreciate Aaron Buck-Burnett and my guests, Dr. Ernst Griffin. You can meet him if you need a neurosurgeon at Cedar Presbyterian Neurosurgery downtown.
We'll be back on the 4th too, by the
We'll
way.
be back on the 4th. Dr. Griffin is an expert in stroke care, and what's coming online for us is he can go in the brain and pull out your stroke, and you can walk out of the hospital without facial droop or weakness in your leg. So that is the future. Thanks so much for tuning in. We'll see you on the 4th, and bring your calls next time. Have a great weekend.